Hello and good evening, good afternoon to our speakers, chairs, and audiences in different parts of the world. We are back again with another wonderful session of ACNS webinars. The first speaker for today is Professor Mark Wilson, who is a consultant neurosurgeon at the Imperial Hospital NHS Trust and pre-hospital Dr. Kent Surrey and Sussex Air Ambulance. He is also a clinical professor of brain injury at the Imperial College of London and honorary professor, the Gibson's Chair of Pre-Hospital Care, Royal College of Surgeons, Edinburgh. His special interests are traumatic brain injury and hypoxic brain injury. He has worked extensively overseas in many medical roles. Professor Mark is also co-founder and medical director of the Good Sam, a platform that is revolutionizing volunteering and emergency services around the world through crowdsourcing care and innovative use of video and AI to aid emergency responses. This and work for www.clinic.co, that is providing a free advanced telemedicine service, has been recognized nationally and internationally. We are extremely fortunate and thankful to Professor Wilson for accepting our invitation to be a speaker at today's webinar. The second speaker for today is our distinguished guest from Taiwan, Professor Chin-Min Chen. Professor Chen is the Director of Minimally Invasive Spine Center, Changhua Christian Hospital, Taiwan. He is affiliated to the School of Medicine, Kaohsiung Medical University as an assistant professor. Professor Shen currently serves as the president of the Taiwan Society of Endoscopic Spine Surgery. As mentioned, endoscopic spine surgery is his forte, and he has published several articles in various peer-reviewed journals. We are extremely thankful to Professor Shen for accepting our invitation to be a speaker at our webinars. The special token of thanks to Professor Sanford Su, who was our previous speaker and recommended Professor Shen as an endoscopic spine expert for our webinar. The chair for the first session for today is Professor Shoji Yokobori. Professor Yokobori is the Director and Chair, Department of Emergency and Critical Care Medicine, Nippon Medical Graduate School of Medicine, Tokyo, Japan. Professor Yokobori is an expert in medicine and is a renowned authority in the management of traumatic brain injury. We are extremely thankful to Professor Yokobori for accepting our invitation to chair the first session of today's webinar. The second chair for today is Professor Yasuake Nishimura. Professor Nishimura is the Associate Professor in Department of Neurosurgery, Nagoya University, Nagoya, Japan. He is also the Chief and Director of the Spine Program in Nagoya University. He was previous fellow at the St. Michael's Hospital Division of Neurosurgery, University of Toronto, and Kremville Neuroscience Center, Toronto Western Research Institute, Division of Genetics and Development, University of Toronto, under Professor Michael Fillings. We are extremely thankful to Professor Nishimura for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers and chairs to this online platform of ACNS webinars. Dr. Liu Bun Seng from Malaysia is my co-host for today and will be the moderator for the second session. And with that introduction, I would like to hand over this virtual podium to Professor Shoji Yokobori.
Thank you, Raja, for your introduction. And I really appreciate Dr. Wilson and to give us a great lecture today. Right, Dr. Mark?
I'm not sure a great lecture. I can give you a lecture. Thank you. Thank you to everyone. Thank you, Professor Yokobori. Thank you for the invite. Okay, so I've been asked to give a little overview of sort of the pre-hospital management and the hyperacute management of TBI, which I'm sure many people are familiar with. My background is that although I'm a neurosurgeon, I do a lot of pre-hospital care. I've done pre-hospital care air ambulance work for approximately 20 years now. And it's an area that I'm particularly fascinated with because, in my opinion, it's the period of time when you can make a really big difference before neurons die. So hopefully I can get across some basic principles that I'm sure most people watching this will know, but translate them into the pre-hospital field. And one of the really important things is, as a neurosurgeon, we kind of think that the pathology starts when you get the CT scan. Actually, there's been an hour, 2 hours, sometimes 4, 5, 6 hours prior to that point where we could have intervened. And that's quite an important thing. So anyway, I've got a little disclosure, which I'm the director of Good Sam, which is, as already mentioned, it's a platform that's now being used by lots of pre-hospital and police and other services around the world to try and improve patient and civilian care, really. So I have this little sort of thing that I start most of my lectures with, which is that if you're not dead, you shouldn't die when the ambulance service arrives or when the helicopter arrives. And it's not entirely true, but it's what we should be aiming for. And the reason why I say that is because we all know about the concept of primary and secondary brain injury. Primary brain injury being what occurs at the moment of impact. So that's the damage that's done at that point. And the secondary brain injury is everything that happens after that. Now, preventing primary brain injury is the domain of public health and road safety and straps and laws and things like that. Our job as clinicians and scientists is to minimize secondary brain injury, the evolving hypoxia, hypotension, and all the other secondary brain injuries that we all know about. But also the expanding hematoma. So if someone is GCS, whatever, but M5 on scene, as this patient was, as his scan here, he had an motor score of 5 on scene. His primary brain injury is not that bad. If you're going to have an M of 5, your primary brain injury is not that bad. So he shouldn't die. And this guy died because of the delays and other problems that occur in that pre-hospital phase. And that's all secondary brain injury that we should be able to prevent. And the involvement of pathology results in harm, and brain injury, that's not just mortality, that's all these other things that can occur with, from depression, fatigue, weakness, change of personality, all those things that can occur as brain injury evolves. And what I think is our privilege as people who are involved in neurological anything, but in particular neurotrauma, is our job is to keep that person the same person that they were. And some of you may have heard of Prof. Steve Peters, who talks about the inner chimp and things like this, which is about your personality and control of that. When we have particularly frontal injuries, it often changes people. It disinhibits them. It changes how they are. They get more agitated, more irritable, and that can lead to a whole spiral of social care problems that we really don't give TBI credit for. And by that, I mean, if you look at the homeless population in the UK, in Leeds, which is part of London, part of England, the homeless population there report having had a significant head injury in about 50% of cases. So 50% of people have had a significant injury. Similarly, with the prison population, a huge proportion, 65%, report having had a significant brain injury at some point in their life. So these figures show that actually there are ongoing sociological effects, and TBI seems to be a disease of the vulnerable and makes people more vulnerable. And certainly in West London, where I work, we see this cycle of people who have a head injury. It's kind of not part of society so much anymore. They get lots of ongoing problems as a result, and this is a terrible cycle which you can get over if you manage people well, not just from a medical point of view, but actually also from a sort of social point of view, looking after them, looking after their relatives, explaining how things are going to be, making sure they get in the correct pathway for head injury care, actually, or brain injury care rather. We can really minimize that. So I'm going to go through the patient pathway in the pre-hospital phase. And I can talk a lot about the whole pre-hospital care systems, which we can talk about if we have questions at the end. But I'm really going to focus on sort of secondary brain injury management and minimization. So the first thing we do is minimize hypoxia. And one of the things we're often not taught about at medical school is impact brain apnea. This is the phenomenon of cessation of breathing when you hit your head. And it's certainly not something that I was taught about at medical school. Your head hits the windscreen. That's the primary brain injury occurs at that point. But then, at least in animals, there's a period of not breathing. And this is an example of an animal that was breathing quite happily. It was a dog. The top line there shows dog breathing away, quite happy. Kramer, at the turn of the last century, put a metal plate on the side of the dog's head, shot the plate, and the dog stops breathing. That's the flat line. He then resuscitates the dog with a dog bag valve mask, and then the dog starts breathing again. If you don't resuscitate the dog during that period, the dog dies of a hypoxic brain injury. You might also like to know that during that period of apnea, there's a catecholamine rise, and that results in what can result in a fall off of blood pressure as well. And we do see that in code red patients with isolated head injuries, which I'll talk about in a second. But in general, it doesn't matter what animal you take, and it doesn't matter how you hit them, whether you hit them with weights, hammers, fluid percussion models, they all stop breathing. The harder you hit them, the longer they stop breathing for. And this phenomenon of catecholamine or sort of collapse, where people have this vasoactive heads, they come in hypotensive. In the UK, we talk about code red, which is people who are hypotensive with a blood pressure systolic less than 100. And actually, when you do all your scanning and everything, you don't find any other injury other than an isolated head injury. And the ATLS teaches us that you can't be hypertensive from an isolated brain injury. It must be hypervolemia, but that's not true. That's a very simplistic way of looking at it. What ATLS means is you can't bleed enough inside your head, but you certainly can be hypotensive from a head injury from the sort of sympathetic and vasoactive consequences of this impact brain apnea type phenomenon. And it's about 15% of our code red patients are actually just isolated brain injuries. And this is a patient that we probably all see not that infrequently. This is someone who came off his motorbike, and he died and his cause of death on his death certificate was traumatic brain injury. And I will just argue with you that he hasn't died of a traumatic brain injury. You can see he's got loss of grey white, he's got sulcal effacement, he's got a face swollen brain, but he hasn't died of a traumatic brain injury. He's died of a hypoxic brain injury secondary to trauma. And that's a really important distinction to make, because if we're going to start treating pathology, we have to know what pathology it is we're treating. So this is a motorcyclist. I say he lost his airway. That was the problem. If someone had held his airway open, he might not have had a hypoxic brain injury. He might not have died. So it's hypoxic brain injury secondary to trauma. And that's what that's what led us to set up the Good Sam system, which you can have a look at if you want to. But basically, it's a system that was originally designed to alert off-duty doctors, nurses, policemen, firemen to go and hold an airway open in trauma. It's now used much more in cardiac arrest, and actually it's used across the world, in Australia and New Zealand, as well as UK and other parts of the world, for alerting people to go and do CPR rapidly following a cardiac arrest, and that's saving many lives. But it was originally designed around impact brain apnea. So we talked a bit about apnea. The next thing we're talking about is like maintaining the airway with intubation. Now, if you go back 20 years, pre-hospital intubation was seen as a bad thing. And that's because there were lots of studies that were done, mostly in the US, which compared pre-hospital intubation with in-hospital intubation. And this is one of them from a guy called Dan Davis. And it showed basically a horrific esophageal intubation rate and far worse outcomes. But these paramedics weren't trained in RSI, or in my opinion, weren't trained in RSI. They attended an 8-hour training course, as it says along the bottom there, and were given a video about how to do an RSI. That is them versus anaesthetists in hospital. So this isn't pre-hospital versus in-hospital. This is untrained versus trained. And not surprisingly, if you're not trained, you do badly. And that gave it a very bad name. But there were organizations, London HEMS and others in the UK, in Australia, the Steve Bernard's group and the team out there with Karen Smith and people looking at properly trained paramedic intubation, and showed that there was a better survival, at least for severe head injuries, with people who were intubating in the pre-hospital phase. And that was a very good study that came out about 4 or 5 years ago now. One of the questions is, what should you intubate people with? And we traditionally use things like etomidate and sucks and things that wouldn't lower blood pressure. We've switched over to ketamine mostly now. Most services have, and the reason for ketamine and fentanyl, but ketamine is because although it may slightly increase ICP transiently, it has other protective properties and doesn't make you hypertensive. You've got airway protection with it, and it's probably got some NMDA antagonism type neuroprotective effects as well. But that's how most of the UK services would do it. And actually, if you look at a success rate in pre-hospital intubation in a well-governed service, it's as good as in hospital. So we should be, this is something that, as long as you do it in a professional manner, is a safe thing to do. And now the question's really moved on about how you should be intubating. Not should we be doing more video laryngoscopy, rather than the traditional Mac or Miller blade type direct laryngoscopy. So let's talk about airway for a bit. We're now going to talk about next secondary brain injury, which is hypotension. And it doesn't matter what study you look at over the last 20 years, they've all shown that hypoxia, these are all different studies here, and hypotension increase your odds ratio of death following TBI. So there we go. Hypoxia, hypotension is bad for you in TBI. I just want you to think about that. Are these causational or are these associated risks? Hypoxia pretty much is, but let's talk about hypotension for a minute. This was a study that you may have seen from JAMA, which shows that for every 10-point increase in systolic blood pressure, you reduce odds ratio by 20%. So that's a pretty good linear relationship there, confirming that hypotension is associated with poorer outcomes. But I just want to put this to you, and this is something that I think is really important about how you look at brain injury, which I'll come to in a second. But if you take a bucket of cancer, all different types of cancers, there we go, lots of different types of cancer there, and you give them those drugs, you will increase mortality. And the reason why is because those drugs are poisons. But actually, one of those cancers in there, testicular, will do very well with those drugs, and they might well be cured with those drugs. But if you do a study where you just keep giving those drugs to all those different cancers in one go, you will show that actually you kill more people. But brain injury is the same. Most studies we do, we lump all the different types of brain injuries, extradural, subdural, all different types of brain injuries together, and then we try and apply a mythical or magical CPP, a cerebral perfusion pressure, to them. But we're not necessarily looking at the underlying types of brain injury within those groups. And there's little bits of evidence out there in some places. This was a study by Jeff Manley from quite a few years ago, where he did the same work that Randy Chestnut did in terms of the trauma coma data bank, looking at secondary brain injury in his own group, but removed everyone who died in the first 12 hours. And as you can see, there's no question that hypoxia increased mortality, but Hypotension maybe didn't. And it may be that actually the people who are hypotensive in this group are actually dying of their pelvic injuries and other injuries rather than their brain injury. And maybe hypotension is not quite as bad as we think, or at least maybe it's not quite as bad as we think in some types of brain injury. And again, this is very, very basic, but often we kind of forget it. Everyone who's watching this will know what an extradural is, will know what a subdural is, will know what contusions are, and so on. But when I ask many of my juniors and colleagues, people say, what type of brain injury is an extradural? Is it primary or secondary? And they look a bit blankly and they go, what kind of brain injury is it? And the answer is, it is not a brain injury. An extradural is a collection of blood outside the brain that if you leave it there will become an ischemic brain injury, or due to mass effect, it will become a brain injury. But an extradural is an extradural. It's not a brain injury. So if you take that out, that person goes home a week later or even quicker and completely fine. They're back to work. Similarly with pure subdurals are just an extraaxial thing. They're not a brain injury at all. Brain injury is parenchymal hematomas. It's diffuse axonal injury. It's shearing injuries that are related to subarachnoid blood, or hypoxic injury, diffuse. They are brain injuries, and those people are not right. And they're the ones that often don't have a scar on their head, because we often do not operate on them. We only operate on the people that don't have brain injuries often. We operate on the people, and they don't have a scar on their head. And they're the ones that actually society looks at and goes, well, Bob looks fine. But they're not. They're actually the one with the brain injury, and therefore they tend to fall off normal societal norms, and things go a bit wrong for them, as in like they lose their job, lose their partner, because they're not quite thinking straight. So what I'm trying to get at is that we don't know which ones of these we should be increasing blood pressure for. It might well be worth the diffuse axonal injury, or diffuse, yeah, we should be increasing their blood pressure in the prehospital phase because they need to maintain cerebral perfusion. But actually, in the extradural group, does increasing blood pressure actually make the extradural bigger? There's not been a study to sort of look at that in any kind of underlying kind of way. So we talked about hypoxia, hypotension, going to talk about intracranial pressure now. And I just want to, again, sort of challenge perceived thought about intracranial pressure. We all know about the sort of closed box Harvey Cushing mentality around intracranial pressure, and it's true, but I want to really go through the history briefly and explain where that came from. So Monro and Kelly, there's no picture of Kelly, that first guy there, 1782, that's Alexander Monro II. He said all those words that you can read there, and basically, if you put something in your head, you push blood out, is what you were saying. Kelly said the same thing as his student in Edinburgh. And then Abercrombie, who was in Leith, who was a pathologist there, he said something very interesting. He said, no matter how you die, the volume of blood in your cranium is always the same. And I want you to think about that for a second. If I shoot you and you bleed out and you go to postmortem, your spleen will all be shriveled up. If I shoot you and you go to postmortem and we then cut your head off and drill a burr hole and let the blood out, the blood volume that we get out would be the same whether you were hung, died of pneumonia, or anything else. The blood volume in your cranium is always the same. And that's because your cranium is doing something else that we often don't give it credit for. We think your cranium is there to protect you from sticks and stones and things being thrown at it. But your cranium is there to protect you from the atmosphere. And we know that with syndrome of the Trefine. But if you don't have someone's cranium there, then that bit of brain doesn't get perfused because the atmosphere is doing it. So that's what Abercrombie said. And the next guy, Magendai, everyone goes, oh yeah, I know, I've heard of Magendai. He discovered foramen Magendai. He also discovered CSF, which most people don't give him credit for. But because he discovered CSF, it meant the Monro-Kelly doctrine could be altered by a guy called Burrell, who was at UCL, UCL, and he said, okay, I'll revise the Monro-Kelly doctrine now, and we'll talk about not only pushing out venous blood, but also pushing out CSF since it's been invented. No one really liked Burrell. Everyone liked Harvey Cushing. He said exactly the same thing as Burrell, but everyone remembers what he said about the skull being a closed box. And that's where we get the ATLS kind of graph of ICP versus mass there, blood clot, tumor, whatever it might be, and eventually you decompensate, push it out. This is a fantastic static model of intracranial pressure, but it's a static model of intracranial pressure. Now, I want you to think about now, sitting where you are watching this, you're pumping a litre of blood into your head every minute. A litre, that's a huge volume. If you take the top of your cranium off and scoop through your brain out, the entire volume of your cranium is about 1.3, 1.4 litres. So you will fill it with blood in a minute, or just a minute and a half. And you've got to get all that blood out as well. So it has to come out your jugulars, basically. There's not many other places it can come out of. And if there's any mismatch between blood in and blood out, that will jack up your intracranial pressure far faster than CSF that you're producing at 0.03 mils per minute. So the ratio of in-out of blood, the dynamic is far more important than this accumulation of hematoma or whatever it might be in majority of cases. And to give you an example of that, if you're hypoxic, this is an experiment we did about 10 to 12 years ago now, with someone normoxic on the left there, and then making them hypoxic, you can see you get venous distension, and that's because they're jacking up their blood flow so much they can't drain blood quick enough. So the way I think about intracranial pressure is not just what's going on inside your head, like the expanding hematoma, but I think about, are they having their neck compressed by their collar or whatever it might be, which we all know pretty well? Are they hypoxic? This person here's got you know this when you're in intensive care. If they've got a whiteout on one side, they're massively increasing their cerebral blood flow because they're hypoxic and they're trying to maintain brain oxygenation, like someone on Everest. And therefore they're increasing their cerebral blood flow. They can't drain quick enough, like IIH patients, and therefore they jack up their pressure. And then the other really important thing is the abdominal side stuff, all connected with the IVC and SVC. If you're doing a craniotomy at the same time someone's taking someone's spleen out, you will see that when they start to close the abdomen, the brain herniates out at you because it's all connected. So in the pre-hospital phase, if someone puts the oxygen cylinder on someone's tummy, not surprisingly, you're jacking up their intracranial pressure. So don't just think about intracranial pressure as the pressure inside your head. Think about the whole body as being related to it. And as some of you will probably know, Scalar in the US does decompressive laparotomies, not craniectomies, laparotomies to reduce intracranial pressure. So it is much more than just the simple way that we've often been taught about the skull being a closed box and it all related to extraaxial or contusions inside your head. So the other thing we talk about a little bit is about reducing with other ways, such as hypertonic saline or mannitol, and there's studies that started now looking at which of those is best, or maybe nothing is better. We don't actually know that actually this improves outcome. So we talked a bit about hypoxia, hypertension, intracranial pressure, now talking about end-tidal CO2. In the old days, we used to hyperventilate people to lower intracranial pressure, but actually the work of Jonathan Coles and others in Cambridge showed pretty clearly that hyperventilation not only lowers intracranial pressure, but it also lowers cerebral perfusion. So now we tell everyone pretty much aim for normal end-tidal CO2, and there's not much more to say about that really. Cooling is another thing we talk about, not in the pre-hospital fair, but on intensive care as well. And the Eurotherm study, which cooled people to 32 to 35, was stopped early because of increasing mortality. Okay, that's an ITU study, but what about if you give cooling really early in the pre-hospital phase? Well, there was a study from Jamie Cooper's group in Australia using, in the pre-hospital phase, using cold saline to cool people, and it showed no evidence of benefit in the pre-hospital phase. But I would argue that's not a great study. This is not showing that cooling people does or does not improve outcome. It shows that giving people cold saline doesn't improve outcome. And similar with the cardiac literature, you've got to look at the ways you're cooling people. Infusing people with cold saline is a bad thing. It doesn't do good for lots of things in terms of swelling, hearts. It's not the same as putting a cooling helmet on or something else, for example. So the jury's, I think, still out on really whether cooling is a good thing or a bad thing. So next thing, stopping bleeding. Now, many patients that we see are older, and that's certainly changed over the last 20 years, with many patients on some form of anticoagulant. And actually, if you look at in London, 40% of the patients we see with traumatic brain injury are either on an antiplatelet agent or on an anticoagulant in some way. So one of the common ones that, well, more common ones that used to have was warfarin. And on scene now, when we arrive with the aircraft or with the fast car, we can on scene do a near side INR check. And if their INR is abnormal or abnormally high in their we think they've got a brain injury, we will give Octaplex or Baraplex or other a prothrombin complex on scene to try and reverse the INR immediately. And that I think that makes a big difference in terms of timing. The ones that we struggle with are the NOACs because or the DOACs rather, because they are their reversal agents are far more expensive and not so easily available. Although there may be stuff that will change on that imminently, but they're the ones that I really struggle with. The other things that I really struggle with is this kind of patient who comes in from, this is in the emergency department, comes in from a nursing home. You don't know what they're normally like, and they come in GCS 14 confused. Maybe that's normal for them, and they've got a scan like that middle picture there, a small amount of subarachnoid blood. Okay, that's fine. They're on aspirin or something. Well, what do? Do you give them platelets? We wouldn't, and the patch study kind of implies you shouldn't from an ICH point of view. But then 3 hours later, they have that second scan there, where they've got a whole much bigger bleed. Now, there was a period there where we could have intervened and minimized that secondary brain injury, and we've missed it. But how do we minimize that secondary brain injury? Is it tranexamic acid, which we can talk about in a second? Is it other things that we can be doing to try and minimize clot or contusion evolvement? And that's what I find quite hard. Now, as I said, Crash 3 was a study that's reported I think a year ago, just over a year ago, and it basically showed that using their study that in mild to moderate head injuries, giving TXA improved head injury related mortality. Now, there's a few issues with the Crash 3 study, and people will shoot it down in that one, it wasn't really initially designed to look at head injury related mortality. That's not a concept that people normally study. Most of the patients on my ward don't die of head injury related mortality of their head injury. They will die of their pneumonia or something else. So it's difficult to say what actually is what's what in this. And it was also, they also clumped mild and moderate together, which they weren't supposed to do. But it still showed some statistical, well, some form of benefit from that patient. And I suspect, although it's not really gone into, that actually those sorts of patients who are on aspirin or clopidogrel are the ones who really benefit from this, or the ones who might have evolving contusions because of alcohol and other things. But as a result of that, we now guide people to giving TXA in the hyperacute phase. The earlier you give it, the bigger the difference it makes. Now, there are other studies out there which show no evidence of benefit from TXA. And the reason why I just put this out there is that TXA probably makes a difference in some patients, but we mustn't get so hung up on it that we stop doing the basic care. We don't look after that. And I've seen this on scene where people are trying to get the TXA out of the bag rather than looking after the airway. Look after the basics properly, and then you give your TXA whilst you're en route to hospital. So that's quite an important sort of thing to think about as well. The only other thing to think about is when you're sending patients home after they've been admitted to you is, do they really need to be on the DOAC, NOAC, warfarin, or whatever they've been put on? And we have things called the HASBLED study, HASBLED criteria rather, and the CHAD-VASc scores to look and see what someone's stroke risk is. But all these studies are based on slightly out-of-date data. And if you ask hematologists, they all talk about this paper from 1999, which showed that basically you had to, the summary of the editorial of it was that you had to fall over 295 times for the risk of being anticoagulated to outweigh the benefits, as in your risk of stroke is far higher than your risk of a subdural. And this is kind of nonsense. This is based on studies in people who are under 65. And if you actually read the paper, which I don't know if I've got on here, I haven't got the rest of the paper on here, but actually there's the numbers that were not known. So most of the numbers were made up as part of this. And I would argue that most of our patients are now in their 80s, and they're not under 65, and their risk of they're falling a lot more. They fall all the time. And so we need to possibly think about if you're, yes, we should be anticoagulating people if we think they're at high risk of stroke, but actually, if they're also at high risk of falls and they're falling once or twice a day, should we be anticoagulating them? And that's another debate we can have probably separately. So I've talked a bit about pre-hospital secondary injury prevention, and I'm now going to talk briefly on the future and some of the things that we're doing around triage and logistics to try and improve pre-hospital management. So one of the things is diagnosing earlier, and that can be through biomarkers or it can be through imaging, are the main two ways. So biomarkers are things that are released, usually from neurons or supporting cells that signify brain injury. And the one that everyone knows about is S100, but there are many others with GFAP, NFL probably being the leaders, and UCLH1 probably being the leaders in the up and coming near side testing kits. They all have different profiles of, well, once they're released, and they could be used potentially for looking at prognostication as well. Some other ones that are out there are purines and microRNA, and we don't really understand how microRNA works, but there was a paper that was released last week by Tony Bailey's group showing that in concussion, you get microRNA rises. And that's really exciting in the concussion world. But it may or may not be quite so good in the sort of higher end TBI world. And as I say, you can divide the stuff into being released from neurons or being released from sort of the astrocytes supporting them. S100 is the one that's been studied most, and in Scandinavia, they will do an S100 level for people who are GCS 14 or 15 following a head injury as a sort of rule in, rule out to then go on to a CT afterwards. And actually, if you look at the data around this, it's actually very, very good. There was a study in New York which showed that if you of 662 people where they basically did the S100 levels and still scanned them anyway, and they found that it was very good. It was sensitivity of 97%. So only one person that was negative from an S100 level point of view actually had blood on CT, and it was an irrelevant amount. It didn't need anything doing anyway. So it's a pretty good tool, but it actually would reduce, if you follow that criteria, it would reduce CT scanning by a third. And if you think, and certainly in the UK, we have a lot of drunk patients come in on a Friday night, like last night, who end up getting scanned, and actually they're just drunk. So if this was a tool that could minimize radiation dosage, that would be quite a useful thing. If it can be used in the pre-hospital phase as well, to then dictate whether someone goes to a neurotrauma center or to another center, that would also be quite useful. Purine levels, purine goes up extremely rapidly in stroke. So if you measure purine levels whilst doing a carotid endarterectomy, it rapidly rises. The problem with purines is they're probably not very specific to brain injury. They probably also rise with leg or other ischemia, which might occur in general trauma. But actually, it would, we're doing studies at the moment looking at this, but if purine works, purine will be a very fast diagnostic tool of a probable TBI. And I say the microRNA work is really exciting, especially in the sports related concussion world, where actually you kind of want to know whether people can return to play and things like that. And that's a saliva test that's being done. So we talked a bit about biomarkers. The other thing I mentioned there was imaging. In the pre-hospital phase, imaging is kind of in two things, really. There's near-infrared spectroscopy type imaging, where you use infrared light to look through the skull, and blood clot absorbs near-infrared light 10 times more than brain. So if you've got a blood clot under it, then the light won't get through, and you can map out a hematoma as a result. Again, it's a useful tool probably in people with lower GCS, but it's not very sensitive / specific. If you've got a subgaleal hematoma in the skin, it will also look positive, if that makes sense. That's an infrascanner. We're doing work looking at multi-channel NIRS machines to try and improve that. But these are all huge. They need to be the size of a small shoebox to be used in the pre-hospital arena. And then some of you are probably aware of mobile stroke units. So actually these carry CT scans, and there's now a helicopter that carries a CT scan on it as well. And they do this for strokes. They can look and see whether you're having an infarct or a bleed for a stroke perspective, and then thrombolize you as appropriate. Now, if we can do it for stroke, could we do this for TBI? Then we know what the early diagnosis is, and it might affect our management or might personalize our management more to that patient rather than just applying the generic TBI protocol to them. And the other side of things, this is the last little bit really, that I'm very involved with, is improving logistics of TBI management. This is, for example, using gyroscopic data from cars to predict how severe an injury is and whether someone's likely to have a head injury, and then maybe that triages the emergency services response slightly differently. This guy here, Mazdak, is doing some fantastic work looking at computerized computational modeling of TBI from CCTV and other similar things, and actually can very cleverly map what kind of injury people have from the mechanism that they've sustained it. And maybe again, this could help us in the future. But the one that I'm very involved with, which is the good something that was mentioned at the start, is the ability to see what's going on scene. And this is basically a system we've set up which can open up anyone's smartphone cameras without the need for Skype or Zoom or any kind of FaceTime-y kind of thing. They just click the link, opens up their cameras, the stream flows, and then the call dispatcher, whether it be police or fire or ambulance, can see what's going on scene and dispatch appropriate resources. And in my world, that's about triaging the scene, the mechanisms of injury, and triaging the patient, how sick they look. And this is just a little simple bit of video here. It's computer generated. Simon Carley from Manchester created this. This guy on with a head injury is going to get more sick over the next about 40 seconds. And I want to imagine you've dialed the emergency services. They're going to ask you certain questions. They're going to say, is he conscious? And you go, sorry, they're going to say, is he breathing? Yeah, he's breathing. Is he conscious? Yeah, he's conscious. So this man is conscious and breathing. So he's not particularly urgent. Conscious and breathing makes him a green 2. You've got 90 minutes to get to him. But imagine you can see this guy as well. Now you're on the phone again. Is he breathing? Yeah, he's breathing. Is he conscious? Yeah, he's still conscious. So he's still green 2. He's not particularly urgent. But I would argue that this man is sick, and you know he's sick. Your eyes can instantly look at him and go, he's hyperventilating, he's sweating, he's grey, he's ashen. And your eyes are better than artificial intelligence. You put a whole load of stuff together within seconds and say sick. And that man can't wait 90 minutes for a response. So what I'm trying to say is the audio that you get on an ordinary emergency call is useful, but not as useful as actually seeing what's going on. So when someone says, my husband's fallen down the stairs, and you can see that he's elderly, he's landed on marble floor, you might be able to get an idea of his Glasgow coma score as well, whether it's flexing, localizing. You can say, oh no, he's going to need intubation in the early phase. I'm going to send the advanced crew to him. Or you might say, actually, no, he looks fine. I don't need to waste my resources on seeing this guy. He can come in via a taxi or something. So you can resource manage so much more appropriately, but you can also care more as well on scene. So, okay, before you go near this guy, there's a saw there. Can you just make sure that that electric saw is turned off at the wall before you go near him? You can look after scene safety. We're doing some work around stroke. So when people say, I've got a weak, or I've got a numb face, actually you've got a weak face, can you lift your arm up? Okay, you're having a stroke. That person needs to go to the Hyperacute stroke unit. And that video can be forwarded to the ambulance service, the air ambulance, to the police and the fire service for situational awareness and various other things. And we've got lots of studies now that show that it makes a difference in about a third of patients, as in either upgrading or downgrading the call. And I'm going to show you this bit of video now. This guy dies of what I said at the start was hypoxic brain injury. This bit of video is horrible, but it was released by the Metropolitan Police. And which is why I can show it. But you can see that he is assaulted, and all these people sort of mill around. Eventually someone dials 999, but imagine, and they're very happy to film it for YouTube and all sorts of things, but imagine you could actually see what was going on when they do dial 999. Actually, he's face down, his mouth is on the floor. As a call handler, you can advise and say, actually, guys, I need you to help me here. Can you hold his airway open? And all that stuff we started about at the beginning in terms of impact brain apnea and hypoxia, we can start to treat people way before we even get there, which is a massive shift change in sort of saving neurons for these patients who are potentially hypoxic and needing urgent care. And in the last sort of, I've got 4 more minutes left, also just about how we can improve the earlier management of in-hospital care as well. So we looked at the very sort of common phenomenon of fixed dilated pupils, which are used as a marker of futility, as in like don't bother to operate on them. We did a meta-analysis of some papers a few years ago, which actually showed if you had extradurals, the outcome's not that bad. It's actually pretty good for people with extradurals with fixed dilated pupils. With subdurals, it is pretty bad. But the average time to operation for these patients was 4 hours, even after their fixed dilated pupils. So look at the mechanism of injury, look at the age of the patient, look at the actual brain injury they have. Certainly people who've got atrophic brains can tolerate huge amounts of blood and still do quite well, even if the shift has been so bad that it's affected their pupils. And the other thing briefly to talk about was really about progressing to decompressive craniectomy where required. There's now some good evidence that people have got raised ICPs for more than 25 for prolonged periods, that actually decompressive craniectomy improves survival. I'm sure most people watching this will know this. It improves survival, but it does also increase your poor outcomes as well. So on average, you get 22 more survivors, but there'll be a very significant number of them with a relatively poor neurological outcome. But that's a kind of separate talk to this. I know you've got Hutch talking in a couple of weeks, so I won't go into that. The other thing about, so a lot of these patients, obviously they do very badly. This was a brief study from the Bristol group showing that actually even the people who've been diagnosed with what we call devastating brain injury, which is a very complex term, I don't really like it, but actually when you manage them, you can still get people who survive and do reasonably well from this group. And actually they basically admitted everyone who was diagnosed as devastating brain injury, who would normally be managed just in resus and just sort of with the tube pulled, they were managed on ITU, and they had a couple of very good survivors from that. But that did lead into what we've developed, which is the devastating brain injury guidelines. It's basically saying we should probably manage patients mostly on intensive care. So even though it seems like it's futile, get them to intensive care, confirm all the history, all that you know. Gives you time for the patient's relatives to be involved, and potentially time for them to become organ donors. And actually, you can. That's actually obviously a very significant thing in terms of both for the family, who then feel there's benefit, and also in terms of outcome for other people as well. So that's basically 40 minutes. I hope that was useful. There's lots of people to thank. If there's anything you want from, or any questions you've got, or anything you want to collaborate with, or anything like that, please do let me know. My email address is at the bottom there. Thank you very much.
Thank you so much, Wilson, Dr. Wilson, for your great lecture. And yeah, actually this time for Q&A session, so I can find some. Okay, So from the Dr. Gupta, about the traumatic vasospasm diagnosis and treatment. So can you hear me,
I can hear
Dr.
you.
Gupta? Excuse me. Okay. Instead of him, so I'll ask you about how do we can diagnose the traumatic vasospasm, and how do we treat that traumatic vasospasm. So if you have a thought or a good comment, please tell him. Okay.
Yeah, I mean, so I mean, obviously, vasospasm with subarachnoid hemorrhage, aneurysmal subarachnoid hemorrhage, is a thing that we know nimodipine helps for. As far as I'm aware, there's no good study that shows that nimodipine is useful for traumatic subarachnoid related vasospasm, and that might be partly because there's not been the proper studies done. It's not something that I use because obviously everything you do, and this is another important point actually, I didn't really emphasize that everything we do has another effect, and I would say that nimodipine probably does similarly. So I would manage the patients as optimally as you can with the basics, and if it was an ongoing problem, you might consider some kind of INR solution. But normally, it's not something we see that often, and have to treat specifically. But just going back to that, I think it's just a concept that I really believe in, which is that we need to be aware that everything we do has a knock-on effect. So when someone's on intensive care and we put them to sleep with propofol, we lower their blood pressure because that's what it does. Oh, so then we have to give noradrenaline to increase their blood pressure again. And when we give noradrenaline, we actually then reduce their gut perfusion, and therefore they get translocation of bacteria, and they're more likely to get septic, or they're going to get or the fact they're on a ventilator means they get into with a ventilator-associated pneumonia. So although we think what we're doing is the right thing, everything you do has a knock-on effect, and I think we should always question things and say, is what I'm doing better than nothing? As in, like being in the recovery position with a blanket is the ultimate in nothing, and always question what we do, and sometimes I think we make things worse by intervening. Yeah, there's another question. Shall I answer that one?
Yeah. Okay. So yes, can we use phenylephrine instead of adrenaline instead in first line? So yeah, Dr.
You can do.
Gupta.
We cannot to use. I've not used either in my pre-hospital experience in recent years at all. That's a kind of peri-arrest sort of use if you're using it, and that's because we would give blood for people who are hypotensive. We would give blood rather than adrenaline. So yeah, I don't. Yeah, it's not something I've needed to give, or to be really frank, just use simple things like lifting their legs up and giving them their own 1.5 liters of blood from their legs is a simple way of giving an auto transfusion, which kind of leads into the next question about should a scoop and run policy for early management of ABC is advisable or shift to neurosurgery, and that's in a resource constrained setting. So that's a really good question, and I've realised that the lecture I've given is very UK based in terms of the resources that are available, and I'm sorry for that, but that's kind of what I work in and what I know. But you're absolutely right. I think doing basics well doesn't actually require very much in terms of resources. It requires transport, but actually, as I said, I don't know really. And if you look at places like Scandinavia, where they'll use the lateral position to put patients in rather than supine, you can manage someone's airway in a recovery position, and you don't need to worry so much about their neck if it's neutral-ish. Holding their airway open, transporting them. If they vomit, they don't aspirate it. All that basic care is really, really important, and then progressing, not at ridiculous speed so that everyone's feeling sick and everyone can't do the basic level of care. Progressing at a sensible speed to the neurosurgical center is probably the right thing to be doing. But so it's not saying scoop and it's not saying stay and play, because no one should stay and play really. But it's doing things as long as you're doing a meaningful intervention, as long as it's benefiting someone, then you should be doing it. But otherwise, you should be moving, if that makes sense.
Okay, and any other question is from also the Dr. Gupta.
Oh,
so yeah, he said he meant to use phenylephrine instead of adrenaline to raise BP.
Yeah, you know what? It's something that I don't have experience of. We don't see vasospasm that much in our traumatic patients. But we would I think it's perfectly reasonable to use whatever you're used to using. But making sure the patient's properly filled, first of all, i.e. not their hemoglobin's okay, but actually making sure they're filled, their blood volume is correct, is more important than necessarily giving pressors, which then go on to have secondary effects that you might not be counting on.
I got, okay. And in your country that you use ICP monitor, right? And
yeah, I haven't talked about that at all. So yeah, most people use ICP monitoring, and you can, obviously the Randy Chestnut paper from a few years ago, which showed no evidence of benefit, but that was ICP monitoring versus another form of ICP monitoring, which is CT scans. So I think you should do one or the other. The thing to think about in ICP, they did, I think, about 390 patients. I can't remember the exact number, but actually, the ones that you worry about are those people who are dissecting or have something else going on that the first thing you're going to know about it is when their pupil blows. So I'm not so worried about using it as a guide for titrating your medicines and maintaining a CPP. I utilize it more as a tool for giving an early warning to the patient that's deteriorating, where you've got no other ways of looking and going on what's inside the head, if that makes sense.
And how about you are using about the biomarker or additional monitor with ICP, solo ICP? So
yeah, so some places will use microdialysis. We don't use biomarkers where I am yet. I think that they're about to come, in the sense that obviously there's a number of organizations or companies rather that are producing biomarkers on a commercial level that will be near side testable. So you get the result back the same day, not tomorrow. And then it becomes a potentially useful tool. It's similar, a bit like Lycox, really. I think it's useful to use these tools and to know them, but you mustn't get so swamped down with them that you then don't do the basics. And I see that with Lycox, where people get fixated on a number and they'll jack up the FiO2 to try and improve the brain oxygenation. But actually, what you might be doing is increasing atelectasis, giving them a chest infection, and all the other knock-on effects without realizing it. So the people who are looking after these patients really need to understand the whole gamut, not just the number, if that makes sense.
Yeah. Actually, we cannot. So it's pretty much for our discussing, but it's time for finish. Okay.
Thank you very much.
Thank you. Yeah. And I will hand over to the Dr. Nishimura. Could you start, please? Thank you so much, Dr. Wilson. Thank you.
Okay. Thank you. So we can proceed to the next session. So I'm very happy and I'm very honored to be here and chair this great session. And the next topic is endoscopic spine surgery. And I have not that much experience of endoscopic surgery. So I would like to take advantage of this great opportunity to learn tips of endoscopic spine surgery. So Professor Chan, please start your lecture.
Okay, thank you for everyone. I'm also a nurse, as I'm not an orthopedic doctor, as I will share all my experiences to everyone. Continue. So it's my great honor for Dr. Xu Feng invited me to join the ACNS. I'm Jianming Chen. I'm also a neurosurgeon. I'm director of Minimal Invasive Spine Center, Zhanghua Great Hospital. I also the president of the Taiwan Society of Endoscopic Spine Surgery. You know, I also do the pediatric surgery, but I do the endoscopy 20 years ago. You know, I'm also the pediatric surgeon. We know the endoscope in the spine surgery, they have the biportal surgery, they have the uniportal, you also will see the MED. Now, today I focus on the uniportal. We call it a full endoscope spine surgery. We also have some society with Japan, Korea. We have the, you know, this month we also have the webinar over 100 people join this meeting. We also correct the name. We don't call it percutaneous, we call it a full endoscope spine surgery. So you can see the paper in the L spine. We know the endoscope Before the 20 years ago, I started to do the endoscope. We find that the endoscope is less invasive because even you do a microscope, you will need to sacrifice some bone structure. So after remove the disc, you also will find some muscle damage and some bone sacrifice. I remember 20 years ago, I have a migration disc, but 20 years ago only focus on the disc. So I do the endoscope, but I fail. So I immediately do the microdiscectomy because I have residual disc here. So I think about how to discover this problem. In the 20 years ago, it's not easy because the time we don't have the bird, we don't have a laser, we don't have other special instrument. The endoscope is not good. But now it changed. You can do anything. You can sacrifice bone. You can do remove some bone structure. So I published the paper about how to remove the downward migration, and I sacrifice some bone and remove the disc. You can see here, and sacrifice and do a foraminoplasty, and then I sacrifice some vertebral body, and then you can do a foraminoplasty and subpedicle, retrocorporeal, remove the bone structure, and then you remove the disc. You can see the transverse nerve root. Okay, so after the surgery, you can find a small bone sacrifice in the body here. So this is a disc problem. And then you can see the CT scan. So I published this paper. You can see here. You know, the 2,000 years ago, they have a story about our Guangong. They have the damage in the world. But the doctor will do the local anesthesia. So remove the trauma and suture the wound. How about now? You also can do the endoscope, local anesthesia. Patient can play the game, and then doctor do the surgery. But you need a mode to irrate the nerve root. So the patient can other local anesthesia, and you do the surgery. So patient is a day surgery, you can leave our OR room. And now you can join the International Society of Endoscopic Spine Surgery. Yes, before 4 years ago in Guangzhou. You also can join the AL Spine. The AL Spine also have the endoscope course. This is the AL Spine course. And then you also can join the NAS course. And that's the last year in the 2 years ago in NAS, they also let the endoscope join this session. We back from the history. Before the 10 years ago, only the disc problem we can do the endoscope. So all the technique is only into the disc, but now we do the epidural scope. So you sacrifice the bone and you can do anything during the thoracic or in the spinal canal. So there are so many different techniques. You can do the posterior lateral inside out. You can do interlaminar. You also can do the far lateral outside in technique. You also can do the contralateral approach. This technique is from Korea. It's also my friend finding that. So the history of the full endoscope spine surgery is from the inspiration, invasion, innovation, from the intradisc disease to the extradisc disease and the non-disc disease. It means maybe the tumor, maybe the vascular lesion, you also can do endoscope. So bone symmetric, spine infection, spine epidural hematoma, spine tumor, juxtafascisis, you can do the endoscope. Some special situations, spinal tumor, muscular, but this is focused on some special disease. You can see also published the epidural abscess. You can do the endoscope, and then you can drainage this paper. Yeah, this is abscess. Okay, you also can do the fusion from the endoscope. So use the endoscope to do the fusion tech. and then you do the fusion. In this topic, I want to focus on the decompression. So I back to the our content background. So spinal stenosis is from the ligament or from the facet or from the disc. So you need to sacrifice some bone or remove some disc. So my treatment option is a conservative method through the surgical procedure. So surgical indication is after failure of a conservative treatment. But how to do the decompression? We know the commercial laminotomy, and the new technique is to try to limitation the bone decompression and avoiding removal of a midnight structure like a spinal process or supraspinal ligament. So you can see here, we can do one side to both side decompression, or we can do both side. But how to calculate your decompression is we will calculate spinal canal, and to prevent to avoid damage the facet joint, because if you damage too much facet joint, you will cause the unstable problem. So like this case, some doctor do the transformer, but it sacrifice too much facet, so it causes the unstable problem. So in the lumbar decompression, use the full endoscope. They have two different techniques. One is the endoscope uniportal controllator approach. One is a transformer formuloplasty. If you want to see how to do the interlaminar approach, you can see my paper in the technique consider interlaminar approach for lumbar disc herniation. So you can see a different herniation, and then you can see the how to sacrifice the bone. Okay. Now we have a different scope. You have a large one scope, you have a small one scope. In the large one scope, you can be more faster and be more easy to sacrifice the bone and to do the decompression, a little like the MED or the tuber system. And we also have a large one high-speed burr, so you can quickly to remove the bone structure. You have the dimer burr, and you have a punch. So you have everything in the endoscope, but it's not easy because there is their own one-way duration. It's not easy to like the biportal surgery. We have a different instrument to do the one decompression. So we also do the local anesthesia. So you can see my secretary will do the massage for the patient. So this is also a case showing a 61 male. They have the L1 to spinal stenosis and the correction for the 2 years. And you can see a little bit disc herniation and the severe stenosis here. So I do the interlaminar approach. So it's a uniportal bilateral decompression. We will focus on this a little like a tuber retract system. So you can see almost the same. Spine surgery, if it's not difficult, you think about if you're learning about the tuber system, you can change to the endoscope spine surgery. It's not difficult for the doctor. So you see the same procedure with the tuber system. You will find the spinal lamina junction, and then you burr it, and then you find the fragment, the tip, and then in the caudal area. So you can totally remove the fragment, and then you can see the dura sac from the controllator side, and then you try to remove more fragment. So totally you can do the decompression like this visual. But how to remove the disc? Because you use a large one endoscope, so I will use the channel-in-channel procedure. I will use a small one channel and small one sheath. So a little like our Taiwan special food, channel-in-channel. So you use a small working sheath, and then you can put inside near the dura sac. So you can rotation it because it's a small one. Usually a large one, it's not easy, and you also will cause the damage to the dura sac. Maybe you will cause the dura tears some problem. Okay, so this is a controllated side, and then you remove the disc. And then you found the isolated side, and then you use the switch to rotation it. Okay, then you can remove the disc from this side. And you put the endoscope switch inside. Okay, careful too, because they have an adhesion here. So I will dissection. Endoscope has a special is a water base. So water can put away the dura to prevent you damage the dura sac. And the others, water have some pressure, so also will pull away the dura. And you rotation the small sheath, and then you can remove some bulging disc from this side. Sometimes we were careful to prevent the damage the annual fibrosis, because the large one annual fibrosis defect will cause the recurrence problem. So you need to careful. And the finish remove the nucleus, I will do the nucleoplasty to prevent the recurrent problem. Okay, I will do so finish the decompression. You will see all the dura sac and the lateral recess also will decompression very well. So you can remove some bone, you can remove some nucleus. Pre-operative and the post-operative, you can see the unilateral, bilateral decompression. After the 1 day, the patient will leave our hospital. How about the endoscopic transformal decompression? This is the other case, 64 female housekeeper, and she has a left leg pain about 9 months. We see the MRI and the CT. You can see the disc herniation here and the spinal stenosis very well. So I try to do the transformal. And then now you can see local also you need careful because the pin also will damage the spinal canal. So careful, and the local anesthesia patient will give you any response. And then we do the outside technique. It's epidural scope. And then I sacrifice some bone, and then to the controllated decompression. So step by step, you find the spinal SAP and the pedicle junction, and then you sacrifice that because this junction is far away from the eccentric root, so patient doesn't feel any, doesn't have any feeling. So it's very easy to sacrifice it, and then you can try to, you have a large space, and then you can remove some fragile ligament, and then you try to remove the contralateral fragile ligament here. Okay, you can see the dura sac here. The patient is the other local anesthesia, so sometimes I need to quickly do doing the surgery, and then you try to remove more fragile ligament. After you remove fragile ligament, you will see the dura sac. They have some congestion problem because the long time spinal stenosis, so you will see some dura sac congestion and some dura fall. This is contralateral side. It's a transforming from this side to the contralateral. But it's difficult to the contralateral or lateral recess. So I will stop in here, and then you see the dura sac, almost the both side decompression. So if you do a transformer, it's not easy to do the all the spinal decompression because they have some dura sac where in the midnight. So you can do like this one, but you can do the both side transformer, and then you can do the totally decompression for the spinal stenosis problem. You can see the preoperative MRI and the post-operative MRI, you can decompression. So for the endoscope uniportal contralateral approach, you can do both side facet hypertrophy phalangeal ligament thickening and bilateral stenosis. But for the transformer, you only, if you do the one side, you only can do the phalangeal ligament thickening or the unilateral lateral stenosis problem. You also can see my paper talk about the endoscope for lumbar spinal stenosis. But how about the thoracic and the cervical problem? You know, the thoracic and cervical is a spinal cord. So you need to know the no touch technique. You cannot touch anything. You cannot touch the spinal cord because they will cause the postoperative damage. Sometimes the water pressure, you also careful to don't use the pressure pump because they also will cause the spinal cord damage. I showed some cases spinal stenosis. This is a case is HIVD. So you can see the serial C7 right side HIVD. I do the endoscopy and I find a viewpoint and then I sacrifice. I find a viewpoint. This is we call the viewpoint. And then you sacrifice, you open it. Use a burr to open the viewpoint. And then use a hook. You can see the disc herniation here, no root here. So no root here, but you can see a disc herniation. But there is and try to be careful to prevent damage to the nerve. Remove the disc. So pre-operative, post-operative here. Sometimes you also can see the vertebral artery. You're too deep, you can see vertebral artery here. So you need to be careful. And how to do the unilateral bilateral decompression is different from the lumbar decompression because you do not touch, you cannot touch the spinal cord. So you need to be careful. So little like the tube system, but you cannot touch anything. So you can see this case, I use the navigation guide and then the same procedure with the disc herniation. You find a viewpoint and then this is the viewpoint and then you use a punch. You can see the spinal cord is here. So very close, very careful. And spinal cord decompression. And then you need to careful to start breathing because I didn't put any drain here. So I will start breathing, will close the water and check everything. And sometimes I will use the force field to start breathing and careful to prevent the post-operative bleeding because post-operative bleeding will cause the spinal cord damage. Okay, so I finished the surgery. You can see here the spinal cord here. The train here. The total decompression. For the cervical, the decompression, unilateral bilateral decompression, you can see here. Okay, pre-operative, post-operative here. So the small one. How about the long segment downward migration? You also can use the endoscope. For the traditional, I would maybe from here. So I do the endoscope surgery, and you can see there's no unstable problem. So it's suitable for do the endoscope. I find a viewpoint from the out and down. Then you can use the burr and remove the disc. So we can see the endoscopy view, viewpoint. You can find the two level viewpoint, and then I do the sacrifice here, and then you can see the spinal cord here. Okay, you try to. This is the spinal cord. And then try to on the outside increase the herniation. After remove the mucus, you can see the spinal cord here. Okay, so to finish the surgery. How about thoracic? Thoracic, you will see some rib here. So it's different from the cervical and the lumbar. And thoracic, you can do the transforming. Also, you can transform and to remove the disc. But you will pass through the head of rib, and you also remove some transverse process because of the different anatomy. So we also use the endoscope. You can see here, you can feel the transverse process and the head of the rib. So you remove all the structure. So you can into the thoracic spinal cord. But first, you will find the nerve root here. Okay, you will find the dorsal ganglion here, the nerve root here. And then you can see the spinal cord inside here. Okay, so you can see a spinal cord. You also can do the posterior urinator bilateral decompression. The same procedure with the cervical. So you can see here, urinator bilateral decompression. We will do the local anesthesia. So it's a very, very stenosis here. I do a CT guide, and then you can plan how large one you want to sacrifice, and you can plan here. In here with a red marker, and then I use the endoscope inside, remove some bone, and then I use the burr, and from this side to this side, use a navigation guide. So it's very easy to, but you need to be careful because the inside is spinal cord. Okay, so step by step. Now you can see the thoracic spinal cord here. You can quickly just the spinal cord here. You cannot put your punch forces upper the spinal cord because there will damage to spinal cord. You can to the both side, but you cannot in the spinal cord. You need to use a burr to careful to burr it, and then use a navigation to check it. Use a totally decompression. So after have a large space, so we can remove the disc because you need to touch the spinal cord. They will cause the spinal cord injury. So I remove disc. Okay, after surgery, you can see the thoracic spinal cord. I also put a floor seal to start breathing. This is the floor seal and the spinal cord here. I put a floor seal inside. Okay, this is the floor seal. Okay, after start breathing, you can see all the spinal cord, thoracic spinal cord. After the surgery, the pre-operative, post-operative here. Okay, my total case is not in the thoracic and the cervical. You know, this maybe the population problem. But full endoscopic decompression, maybe you need to achieve a certified effect. You need a step by step because there's learning curve is not easy. So I hope every training you can join the Kadaba course, you can join the model the training, so you can improve your experience. So any question you can through the email, WeChat, or WhatsApp, like you can touch me and I will give you some answer. Thank you for everyone.
Okay, thank you very much for your Professor Chen. Thank you very much for your beautiful pictures and excellent surgical videos. So I have several questions. And,
okay.
It was amazing to see patients who was receiving surgery and using smartphone at the same time. It was amazing. So all endoscopic surgical procedures are done under local anesthesia in your facility.
And it's not all the procedure, other local anesthesia. Sometimes the internal, I mean, if you need to touch the nerve root, or
yeah.
you know, sometimes spinal cord, I also will use the general anesthesia. But if I transform, I didn't touch anything, I can show the can be triangle, I will use a local anesthesia. So if the situation is suitable for the local anesthesia, most of my case, I use the local anesthesia because it will be quickly to leave the hospital.
Okay.
But you need a learning. It's not easy to do the local anesthesia. I know that Japan, in the Japan, there some doctor also use the local anesthesia to do. Yeah.
Oh, okay. So, what do you think the learning curve of endoscopic surgery? I like to. I needed to teach junior surgeons. So, but under microscope, it is very easy to teach the technique, right? We can put both hands and at the same time with the assistant surgeons. But that's a reason why I hesitate to do endoscopic surgery. It's difficult to teach and learn the technique. How is the situation in your facility to teach about teaching and learning the junior surgeon?
I also do the microscope surgery 20 years ago, but I changed to the endoscope. Sometimes it's not easy to learn, but you need maybe 50 case you can overcome. And then I hope a doctor can see how to do the surgery. The procedure is not easy through the paper to tell everyone how to do that. And sometimes the situation also different because a little like a target therapy. Because microscope, you will sacrifice more bone. It's easy.
Yeah.
But endoscope, if you do the local anesthesia, it's not easy. So for the beginner, I will let everyone to do the surgery doing the general anesthesia.
Yeah.
And slowly and to use the endoscope because they will be quickly to learning the endoscope technique. The skill is really different. I know in the Japan, also orthopedic doctor do the endoscope, but neurosurgeon doesn't do endoscope.
Yeah.
Also send the situation in Taiwan, but now we change it. Neurosurgeon also join do the endoscope. Not in the China, orthopedic doctor do endoscope, but neurosurgeon doesn't do endoscope because we have a microscope.
Yeah.
So, but in the future, I think maybe the standard maybe endoscope because quickly, but learning curve is we need to overcome. But you always use a microscope. It's not easy to learn in the endoscope, because you have microscope. Like in my department, some doctor also use a microscope. They doesn't like use endoscope because he needed to learn in the endoscope. Need time. Not necessary. Sometimes, So that I'm younger. 20 years ago, I'm younger, but I don't have a work. I also do the trauma, but now the public traffic also decrease the traffic accident. So hazard is decreased, brain tumor decrease, vascular disease decrease. So I think in the future we need to focus on some spine surgery. If you
I
are
agree.
Neurosurgery department, we need to change it too. We welcome everyone to learning endoscope from me because I like to teach everyone to do the endoscope. No problem.
Okay. So there are some elderly patients who have dural adhesion in spinal canal stenosis. How do you dissect, find the good plane between the dura and adhered yellow ligament or something, a bone or something?
Yeah. So this is the good question.
Yeah.
I like to do the elder patient. Oral core anesthesia, and be suitable for even I yesterday I do the 19 years old patient. I do the decompression. But sometimes you don't need to do the totally decompression. Maybe the one side, because they want to be comfortable, not be cure all the spinal stenosis. So when I do the surgery, decompression partial, and I will put some steroid, the patient will feel very comfortable because he's older. Sometimes I over do a 19 or 18. They have so many clinical disease like hypertension, vascular disease. So local anesthesia, the family and the patient will be accept this surgery. So you know, you some patient very older, we don't have any surgery to do this problem. So sometimes, you know, general anesthesia, in Asian people, they doesn't like that. You know, it's even a traditional Chinese medicine, they think about, I don't want a surgery. I remember last time I go to the Indian people also like to do the endoscope surgery, doesn't like a microscope. Because general anesthesia also need to pay more money for the hospital. Yeah. So local anesthesia is good, and I think in the neurosurgery we need to development the endoscope because most of the doctor in the world do the endoscope is orthopedic doctor. But we do the pituitary. You know, I also do the pituitary scar base. So, she Senbo is also my good teacher, you know. So she helped me. I introduced the endoscope to everyone because I do the pituitary also use the one hand and two instruments. So it's easy to transfer to the endoscope for the spine surgery. Not difficult. You need to believe in me, not difficult. So it's very suitable for neurosurgery to learning and add the endoscope course. Even the ACNS, this society, which also joined it, is the endoscope part. Very important because I think if you don't join, maybe the 10 years later, the orthopedic doctor will have more development than the neurosurgery. So we will lose the chance. That's my opinion. Okay.
Okay. So the last question, you showed a very good technique to decompress use a posterior decompression of cervical foraminotomy.
Yeah.
So I exclusively use anterior decompression for cervical to remove cervical disc, cervical radiculopathy. How effective is that posterior approach for cervical radiculopathy?
You know, in the anterior approach for cervical, it's not good because they have a bigger problem because the disc height will decrease. So most so most scope surgery, and I remember that 10 years ago, maybe from the anterior, but now we do the disc problem radiculopathy, we found the posterior. So in the cervical, that's very interesting. Endoscope is always a change because the instrument, because the idea, and because of the concept, every time is different. So in the Korea doctor do the anterior decompression, but now Korea doctor also do the posterior, doesn't do the anterior. You know, so that's very interesting. That's a history problem.
So you don't remove the bulging disc from the back. You don't remove.
Yeah. I remove bulging disc from the back. I also remove. Yeah, I also remove bulging disc. But you know, I don't remove so many. I just decompression. Yeah.
To avoid decreasing the disc level or disc height. Right?
To avoid the disc height decrease too much because that will cause the former stenosis. Maybe the 10 years or the 2 years later. So it's very important. For the endoscope, we just discover the problem. It doesn't cause like we were careful to prevent the annular fibrosis. You know, we do the lumbar endoscope, lumbar micro decompression. Sometimes we will use a large one forceps into the nucleus. But
Oh,
in the
okay.
endoscope, we only 3 mm instrument into the
Mm.
nucleus. So to prevent the annual fibrosis to large one defect.
Uh-huh.
It's
Okay.
very different.
Okay. So yeah, I would like to start the endoscopic clinical practice in your future.
Oh, okay. Welcome to
Yeah,
Taiwan. Very interesting. I want
yeah.
to go to Japan. Yeah.
I would like to observe your surgery in your facility. Yeah.
Yeah. No problem. No problem. You're
Thank
welcome.
you. So it's time to finish. So
Okay.
yeah, I'm closing this session. Thank you. Thank you very much. Thank you, Professor Chen. Nice, excellent lecture.
Okay.
Thank
See you.
you.
Yeah.
Bye bye.
Thank you to Professor Nishimura
Yeah.
and also both speakers, Professor Wilson and Professor Chen, for a very extensive and informative in both new knowledge and also the technical wise on spine surgery. And I also would like to thank both our chair, Professor Yokobori and Professor Nishimura, for joining our session. On behalf of ACNS and Professor Gokato, I also would like to thank all the audiences who joined this webinar. We're going to broadcast this by tomorrow. So until we meet again next Wednesday, it's a bye-bye from all of us. Thank you.